Say hi, Mom.
All right, so regular rhythm. Did we see P waves there?
Yeah. Yep.
Okay, so Chris, L. If I say, I'm just going to start this way and move down. Nothing personal, take it easy. If you see P waves, what are you thinking? Where is that rhythm generated from? Okay, more specifically, probably coming from, hopefully coming from the SA node, definitely coming from the atrium, right? Okay, so if it is coming from the SA node, what is the intrinsic firing rate you're going to be expecting?
60 to 100.
60 to 100 beats per minute. Do you think that that looks like it's coming from the SA node?
Yeah.
And how did you come to figure that out?
Got P waves before every QRS and they're upright. They look fairly uniform.
Good. They look, yeah, I would say absolutely. Little pointy one kind of deal.
Yeah.
Heart rate's a little bit more than 60, I think. Okay. But how did you get a heart rate of 60?
I counted out the lines. I did the 300, 150, 100, 75.
Okay.
It's between 60 and 70.
Okay. All right.
I think 65.
A little bit more than that. That's okay. All right. So about that, we'll say a little bit more, and we'll talk about that in just a minute. Bob, when you look at this, what do you notice about the QRS complex? And what does the QRS complex tell you about this rhythm?
They're all kind of uniform with each other, and they look kind of regular with each other.
Okay, they're regular, and what does that tell you? Are they wide? Are they narrow?
Narrow.
Okay. So what does a narrow QRS complex, where they all look alike, what does that tell you about this rhythm and where it's coming from?
Ventricles are working supposed to.
Okay, so the ventricles are working the way they're supposed to. They're narrow, so that tells us that the ventricles aren't overacting, right? Okay, so Kat, talk to me about the T wave. What do you notice when you're looking at the T's?
They're uniform. The T wave is normal. It's less than half the height of the QRS.
Okay, all right. So any concerns for you that jump out when you're looking at the T wave in that instance?
There's no elevation.
Okay,
It's fine.
all right. So based upon the presentation, a 46-year-old female complaining of chest pain, and you see something that appears to be somewhat benign at this point, what's your next step?
Well, it's sinus rhythm. I would consider aspirin because you may not see it. It could be a posterior wall or the right side. You still see something.
Okay.
You can't see it now on 6 seconds. You need a 12 lead.
Okay, good. So you need a 12 lead. At this point, you're definitely considering, okay, maybe we need to start, thinking about our chest pain protocol. Maybe we need to start considering doing a 12 lead. Absolutely. These are things that we have to be considering. So, G, when you look at this rhythm and this rhythm strip, so we know that we have a P for every QRS complex, QRS for every P. We know that our T waves are pretty uniform, operate at this point. They're looking pretty benign. And this is pretty regular rhythm, heart rate of between 60 and 100 beats per minute with uniform P waves. Can you diagnose this for me?
Well, based on the EKG,
Yeah, what do you think about that? Yeah,
So
let's-
that's a normal sinus.
I would agree with you. Would anyone else disagree? Agree? Is that a normal sinus rhythm?
I concur.
Okay, excellent. So, AJ, you now are there, and, Kat wants to give an aspirin and get a 12-lead EKG. You put the 12 lead on and basically see more of the same in all of the leads. Okay? So what does that tell you? If you see that with no changes in the ST segment and a 12 lead.
That would be alarming. This would be a little bit different than 12 lead.
It's going to be no significant changes.
Okay.
Okay, in this instance, there's no ST segment elevation or depression.
Well, if that looks good, would you need to do a 12 lead?
If I'm sorry, say that one more time.
If this looks good, why would you do a 12 lead?
Well, look at your patient. Your patient is having chest pain. Anyone who has chest pain automatically gets a 12 lead. Because you're not going to be able to see ST segment elevation or even some instances of dysrhythmias in a standard 3 lead. So you always want to do a 12 lead. Okay? So, Amanda, you have this patient. AJ's done a 12 lead, diagnosed it, said there's no ST segment elevation. Kat's already administered aspirin. What was the dose of aspirin that you administered?
160 to 324.
Okay.
But I wouldn't have given it until after the 12 lead. I checked
How was it
for other medication.
Okay, all right, good. So after doing a 12 lead and ensuring that she didn't have any allergies and all that good jazz, she administered chicken cow's uniforms of aspirin. Milligrams, 324 milligrams PO, okay, of chewable baby aspirin. So What's your next step? What do you do? 12
Um,
leads benign.
I would consider giving nitro, but I don't have a pressure, so I
Okay.
don't want to jump my gun.
So what should you do first then?
Go full set,
Good full set of vitals. Okay, so
pulse, blood pressure.
blood pressure is 180 over 80. Make it easy. Respiratory rate is 30. You're kind of distressed a little. Saying that you've got chest pain.
Is is radiating anywhere or anything like that, or is it staying?
No, it's not really moving anywhere. It's just kind of like right substernal.
At this time, I think that nitro is a good option. So I would give one spray, sublingual, with a 0.4.
You're telling me? Are you asking me or telling me?
0.4
Chicken cows unicorns. 0.4 what?
milligrams
Okay.
of nitro sublingually,
Okay.
and
Okay, so we administer one spray sublingually. As soon as you spray one spray sublingually, Chris, what do you want to do?
Well, before the nitro, I would have gotten IV established first.
Okay. Why?
In case she heads it out.
Did she take any Viagra?
You laugh, but women do take Viagra. It's out there, and it's not just Viagra. It's anything that does what? Vasodilate. Any type of vasodilating medication, you have to use extreme caution with, right? So you want to not necessarily ask her specifically if they're taking Viagra, but get what? A list of medications that they currently take. Allergies. Pat kind of alluded to it a little bit when she said, check the allergies before administering aspirin. But realistically, it's not just about figuring out what they take, because nitroglycerin does what? What are we hoping it's going to do? We want it to vasodilate. Why? Why is that going to treat this potentially ischemic event?
It'll
Go
allow
ahead, Mike.
increased perfusion.
Blood is flowing.
We want to restore whatever blockage has occurred. We want to restore perfusion, okay? Because if there is a situation where we have either they're hypertensive and we have some vasoconstriction, or we have a situation where there's a blockage of some kind, a minor blockage, we want to vasodilate to allow blood flow to reperfuse that area of the heart that's actually not getting good perfusion at that point. We want to reoxygenate, right? So good. And back to Kat, why did she want to administer aspirin?
Prevent any more clots. If
Oh,
there
good,
was
because it's an
clots forming.
antiplatelet, right? Because if this is a situation where you have something blocking part of the heart or a part of the musculature, we want to take steps to actively dissolve that. Okay, so we want to administer an antiplatelet, and that's what aspirin is for us. Now, aspirin is kind of like the lowest of the low when it comes to antiplatelets that we can manage pre-hospitally, and it's not instantaneous at all. So realistically, what is this person maybe buying themselves if we did see ST segment elevation?
Time. Give
Well, they
them a little bit
have,
of time.
yeah, they may have a myocardial infarction. Even if you don't see ST segment elevation, they might be having one. So we certainly want to, rule out our pertinent negatives, make sure that there's no chest trauma, make sure that they don't have some type of a cardiac history, which would give them chest pain, like stable angina. Were they exercising when this happened? What was the onset? We talked about radiation, but did we talk about onset at all before we initiated our care? I mean, realistically, is it going to be wrong with stable or unstable angina to give them nitro?
No.
No, they're going to get nitro either way, right?
Is it muscle pain?
Right. Does it hurt when I palpate? I mean, that's another big thing. Is it reproducible chest pain? Amanda started talking about that a little bit. She said, did it go anywhere? Does it radiate? But pain is a subjective thing a lot of the times. People are going to say, no, it doesn't move anywhere. And at the same time, what does it really mean when it moves? Well, it's kind of jumping back between my stomach and my chest, but it's not really moving. It's just like here. Okay. So is it moving? No. But it kind of goes between the two. Oh, okay, good talk. So again, it can be subjective.
It's also a woman, so you want to see if she's got belly pain or back pain.
Sure. Yeah, so why would you want to do that, Mike?
Because women experience belly pain, or abdominal block pain, for if they have
Their symptoms are different.
Those
from
girls
ours.
are weird.
Shut your mouth.
Yes, girls are gross and have cooties and they're weird. And sometimes sometimes their presentation can be a little bit different. It's not necessarily going to be just chest pain. You might have jaw pain, neck pain, back pain, shoulder blade pain, abdominal pain. I've had a woman who was complaining of like lower abdominal and thigh pain, having a massive wall MI. And you're like, what are you doing? Like, that's not okay. What? You mean you have lap pain? Okay, just get in the truck. So, yeah, I mean, again, these things are going to just kind of throw you for a loop. But back to this woman. So we've got aspirin on board, we've got nitro.
Oxygen.
Chris is starting an IV. What kind of IV would you like to start?
Do a 20 gauge.
20 gauge where?
Cubicle.
AC,
Or
which
distal
one?
first.
Oh, you want to go distal? Okay. Which one? She got two.
Left.
Left? Okay. So she, doing a little bit of this, getting our vein up, putting a 20 gauge IV in. Are you going to put a hep block in, normal saline? Complete your sentences. Come on.
Do a hep block.
You're going to do a hep block? Okay. All right. So secured with a hep block. All right, just in case. Just, there. What are you doing, Mike?
And, run the blood pressure again, see if it dropped from the lunch rate.
Okay.
Just to see the.
Initial blood pressure was 180/80.
Reassessment.
Okay, so now we're going to do 160/60. This way it's easy. Okay. So based on that information, we have a new blood pressure, but what other information do you need to get after administering nitro?
Did it help?
Did it help? What's your level of pain now? What was their level of pain initially?
We don't know.
13 and a half.
Oh, we didn't ask. Why is it really important to establish a baseline with your pain?
You know if it changed.
Because we have to know if we helped, okay? I mean, and you have to also give them a method to quantify their pain, okay? Because my pain that I would call bitchin' is not necessarily your pain that you would call bitchin'. So you guys have to give them a scale that's universally understood. 10 is the worst pain you have ever felt. Typically for girls, it's childbirth, okay? You can't look at a guy and say it's childbirth because they're going to look at you and be like, wait a minute, I didn't feel a thing. She did all the work. So again, you're going to quantify their pain though. So 10 is the worst pain you have ever felt and 0 is no pain at all. You're Jim Dandy. So what are you going to do?
Somebody else uses 0 instead of 1.
Get 0, no pain, nothing, 0. Okay. So again, 0 is no pain. There was actually, I had one and I can't find it. I had a great scale and it was like, 10 was being actively mauled by a bear. Did you guys see this? It was going around Facebook for a while. It was like 0 is like a guy skipping through like a, thing of, I don't know, he's skipping through a field or something. 5 was like, I'm kind of uncomfortable. I might have a broken ankle, but I'm not really sure. I can walk on it. And like, 8 is like, I'm really, guys, this hurts a lot. And 10 is like actively being mauled by a bear. I don't use that professionally, however, kind of gets the point across that this is no joke. So yeah, you want to quantify that pain. That's really important. So let's pretend that their initial pain, just because we were doing 180/80 was 8. And now it's 160/60 and it's 6. So based on that information, do you think we're helping?
A little bit.
What do you also want to reassess at this point? Pain level, full set of vitals, what else?
EKG.
What kind of EKG do you want to assess?
12 lead.
Why would you want to do a 12 lead? Why is it important after administering medication to reassess a 12 lead, even if that first 12 lead was benign?
See if there's any changes.
Why do you think that there might be
Something.
changes?
Pain lowered, so the pain's lower now.
But I didn't see anything significant on the first 12 lead, Mike. Why would I need to redo it?
Yeah, it might be progressing.
Ooh. You were chomping at the bit, weren't you? To say so. Yeah, you were. You were over here like, oh, better reassess it. And I heard you guys back there too. Yeah, absolutely. Because this may be a situation where it's progressing. This may be a progressive event. Just because you see something or you don't see something initially doesn't mean that it's stopped. Okay, you have to constantly take multiple 12 leads. Because particularly after administration of nitro, I mean, obviously we want everything to open, but what's the problem with taking vasculature and opening it if we have a plaque issue?
Moves.
It might move. Okay? The chances of that, at the same time, you have to be prepared. Okay, so absolutely, you want to reassess the 12 lead. You reassess the 12 lead, what? You want to, okay, we want to start transporting. Yeah, we might totally want to be thinking about that. I agree. Because you don't want to sit there and play. You want to get moving, but sure, absolutely. So we're thinking about transporting. We're in the back of the truck now, and we're going to get moving. We redo the 12 lead, and it's still benign. Brian, because you're out of the room, you're back to you, okay? So what do you want to do? They've had 324 milligrams of aspirin. They've had 1 sublingual dose of nitro. We went from an 8 out of 10, 180/80, was the blood pressure initially, 1 sublingual dose of nitro, brought it down to 160/60 and 6 out of 10. What do you think?
Give another nitro.
You want to administer another dose of nitro?
I mean, if it's still, well, she's only had one, correct?
Yes, at this point she's only had 1 dose.
Yeah, what does the second one do?
What's the second 12 weeks?
Completely benign, same as the first, no changes, no ST segment elevation, no nothing. AJ, you okay, honey?
No, I'm good.
Do we
Okay.
know her history? I wasn't here. What was her,
She,
like, any medical?
no one asked yet.
Okay.
We've talked about the need to do it, but we haven't actually done it yet.
You know what, let's do that now that we've,
Good, yeah, okay, I'm in, let's do
once
it.
we've started
Yeah,
stabilizing.
So God forbid they have a bleeding stomach ulcer,
Right.
right?
I
We
don't
shouldn't have done the
want
aspirin, because what would that have done?
Made it worse.
Okay, okay, all right. So, okay, so no stomach, no bleeding ulcers at this point. Past medical history, you know, she had an MI about 3 years ago. She's got a stent. She doesn't know where her stent is because they never know where their stent is. Yeah, right. She does have a pacemaker, but it's only demand. It doesn't work all the time. It only kicks in when I absolutely need it. So do you think the pacemaker's working right this second? No, she's had it for about 1.5 years. No new medication. She has high blood pressure. She takes, she's got high cholesterol. She takes Lipitor, Lisinopril, and a daily baby aspirin.
What were we doing up to, did the pain come on like that?
I was doing
or
laundry.
any
no more than
strenuous
normal.
lifting,
No more than normal, but I was doing laundry.
Any altered mental status? During this whole thing? No symptom?
How does the pain feel? Does it feel the same like the first time?
It's not your turn anymore, Mike.
Yeah, Mike. That might have been somebody else's question.
Has the pain started radiating anywhere?
Okay, the pain is still a 6 out of 10, and it's non-radiating.
It's not ready. I don't know.
Okay.
All right. So now what?
Still a 6 out of 10, so that's probably pretty uncomfortable for her. So let's give her another nitro.
Okay, so we're going to administer a second dose of nitroglycerin. What's the dose and how do you want to do it?
I would do that.
No?
No.
Not your turn.
Nitro is. I don't know.
All right, help him out, team.
0.4 milligrams.
Don't get it.
Sublingual.
Don't
One
you-
spray.
Nah, don't get it.
Just one spray, sublingual.
Yeah, one more.
No, you're not. We don't want to do that.
Why not?
Because it's a horrible idea.
But you can't just say that. You need to tell him
Listen,
why.
we can't keep giving somebody medication who is having no EKG changes, and their only complaint is chest pain. I mean, I could sit here and say that I have chest pain as a 10 out of 10, and we're not, with a normal sinus rhythm at a rate in the 80s, after doing 2 progressive 12 leads and not see any changes. So, the last thing you want to do is bottom this lady's pressure out, and then get to the ER and have somebody who is actually having an emergency that you caused, which is what I don't want.
What do you
That's
guys
just me.
think?
I don't
I mean,
know.
if the
Would
patient's
you still give her aspirin and nitro?
I would still give her aspirin,
aspirin in
a
the first,
initial round of aspirin, an initial round of nitro, and a 12 lead. If we've done 2 12 leads and we've seen no reciprocal changes and we're 15 minutes away from a hospital, is that what the 15 is?
Yep.
Then there's no reason to keep dosing her up with nitro. I mean, maybe a second round of nitro to see if it makes a difference, but once you start hitting the 3 rounds and stuff, I think that you're it's not going to resolve with the 3rd round. That's a fact. Then, the next thing you could say is, well, we can start going to morphine and stuff like that, but, there's no...
What do you mean it's not going to resolve with the 3rd round?
There's no... It's obviously not changing after the 2nd round.
It did change after the 2nd round.
The pain from it.
It went from an 8 out of 10 down to a 6 out of 10 with 1 nitro. It came down from
What's
160 over
Let's just
60.
say that's the
I would
first
give the
round.
second and then reassess after that. I might hold off on the 3rd, but
I mean, here's my question, guys. Does it say, what is your protocol and what does your book say about nitroglycerin? Does it say treatment for EKG changes? Or does it say for chest pain of a possible cardiac cause? And what's it's a guideline? Okay, but tell me what the difference is.
if somebody was having an active MI, that person needs nitro.
But how
Not
can you
somebody
rule
who's just
out?
having chest pain.
How can you rule out that she's not having an MI?
We're doing 12 leads.
But that 12 lead is only going to show you an ST segment elevated MI. And there are different types of MIs that
So
are
we
not
can-
going to cause ST segment elevation.
So yeah, so we can do a 15 lead, 12 lead
Okay,
if we want.
a 15 lead, 12 lead?
15 lead.
So that would be like what?
15 lead EKG. Thank you.
It's a lot of leads.
Thank
Okay,
you.
all right. So, but in this instance, you know, again, we could put all the leads in the world, but if we're not going to see any changes, ST segment elevation changes, the only way we're going to find out if they have in fact had a heart attack is to do what? Labs. Can we do that pre-hospitally? No, our job sucks. What the heck? What do you mean we can't draw labs pre-hospitally? What crap is this?
We can draw them, we just can't test.
Well, okay, we can draw. We just can't get the results of that. Absolutely. So in this instant, would it be wrong to treat this person as if they're having an MI?
No.
Are they symptomatic?
Yes.
Yes. Do we have the medication to treat the symptom?
Yes.
So what do you guys think?
Give it to 'em.
No. This is something that, again, we're giving you the tools. And there's a lot of good arguments for and against. What I will tell you is that National Registry and in your textbook and in the protocols, it does say that you can give nitro. You can absolutely keep giving nitro until you max it out by local protocol, as long as they have a stable blood pressure and they're responding positively. With one sublingual dose of nitro at this point, they had a favorable change. They came down from from an 8 down to a 6. So their blood pressure hasn't dropped a huge amount. Now, if they came down a huge amount, like if they went from 180/80 down to 110/40, are you going to stop? Yeah, because that was a significant drop. And if one sublingual dose of nitro dropped it that much, chances are a second dose of sublingual nitro is going to damage it just as much. So for me, from where I'm sitting, I would say, yeah, go ahead and hit them up with another nitro dose. What are your thoughts? I mean, look at your book. You know, it's difficult. And particularly because we haven't gotten into that 12 lead yet, that 12 lead information yet. It's hard sitting here with half the information, I know that. So yeah, in this instance though, the correct things to do is continue on with your protocol and say, yes, we're going to administer another dose of nitroglycerin. We've maxed out on the aspirin, we can administer our next dose, our next medication we can deal with is nitroglycerin. So we're going to go ahead and give them a second dose of nitro. So Brian gives them a second dose of nitro and the dose is what?
0.4.
0.4 chicken cows unicorns.
Okay.
0.4 milligrams.
Is it 76 degrees Celsius outside? 74?
Okay, listen, dude. All right, Larissa. We've got 2 doses of nitro, but point taken. 2 doses of nitro on board. We've got our aspirin on board. What are we doing?
I would have given her oxygen before I started giving her aspirin.
Okay, so aspirin.
Oxygen.
So, yeah, oxygen. How much oxygen would you have administered?
15 liters.
How much?
15 liters per minute.
Okay.
What was her pulse ox?
And what's your presentation? What's the other thing?
But I thought that we were, with chest pain, that we would use Mona, which starts with oxygen first.
Okay. But what's the information with oxygen that we now know?
That it has free radicals.
So if we give over 100% oxygenation, what happens to that oxygen that's not being used?
And it's all over. But doesn't that help?
It does help. Oxygen does help, and there's a lot of scientific evidence out there that says anyone with anyone with chest pain at all gets oxygen.
We could give her a nasal at 6. That's fine.
Okay,
Might be
or
less.
4.
Or 4.
Yeah. Yeah. But next time you guys are bored and playing around, go in, take a nasal cannula, and set it at 6. It's painful. Yeah, it's painful. But yeah, so 4 to 6, okay, and you're obviously going to titrate. What do you want to see on the SpO2? What's the pulse ox reading that you want to see in this instance?
Greater than 94.
Greater than 94%. Okay, so absolutely. So oxygen is on board now. So what else do we have going
on? By the time we got done with our second nitroglycerin, we should be hospital.
Yeah,
Aren't we there yet? What the hell?
Okay,
Okay, all right.
Wrong turn.
I
Okay,
don't know that I would do anything else other
How
than
about-
monitor.
Instead of
My turn.
vitals,
and it's your turn, Ian.
So another reassessment since we provided more interventions.
Okay, so
How's
another
the
set of
pain?
vitals. We're backing in. Larissa is backing into the bay now.
Okay.
Beep, beep,
Disconnect
beep. Getting another
everything.
set of
Set of
vitals.
vitals. How's the pain? Has it changed at all? Is it better,
Pain
worse?
is down to about a 4 out of 10.
All right, we'll drive you back home.
And we'll drive you back home. All right. We're at a 4 out of 10. This IV is really hurting Al. And blood pressure is 140/60 at this point. Respiratory rate is fine. Everything else is good.
Why is the IV hurt?
I don't know. Why does it hurt? What do you need to check?
Go look at it.
Infiltrated.
Is it for infiltration?
Well,
Are there
Shram
signs
put
of
it in, so-
infiltration? Is it blah, 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 blah?
Shram's fault.
We should
Oh,
ask
yes.
I mean, if it's just a hemlock, we were running anything through it.
Okay, so it's not hurting. There's there's a little bit of blood coming out, but IVs hurt. People complain about it all the time. Take a look at it. Tell them if there's nothing, if there's no signs of leaking and you're not infusing fluid, IVs hurt. I stuck a needle in your skin.
I'm sorry.
So, all right. Questions about this one?
Nope.
Yes.
Still there.
We also do, before we got to the 4 out of 10 and backing into the hospital, pain management.
Okay. So, what kind of pain management did you want to do?
Fentanyl, she's got an increased respiratory rate.
Did I not talk?
I missed it, did you?
Holy cow.
I missed it, man, I'm sorry.
All right. So, is it wrong to give this person fentanyl?
Absolutely.
She doesn't need it.
Absolutely.
They're gonna keep going.
Is fentanyl part of your ACS protocol?
Yeah.
I know I do, but
Okay.
protocol. That's the only reason.
So talk to me, guys. Come on. Either support or back. Let's have a conversation about this.
It's
Her pain
going
lower.
down, so why would you give pain meds?
I wouldn't give them.
Yeah.
Something's doing, you're doing
Nitro's
something
bringing
right.
it down, so.
She's down from an 8 to a 4. We cut her
Especially
pain
if
in half
it's
and we're at the
idiopathic, right?
hospital.
Well, that's why I said before we were at the hospital and it was dropping.
Well, we know that students are gonna keep all the pain meds.
Depends on how annoying she is.
Do you really
Listen,
wanna
we are
do
not
that?
snowing her to intubate her. No. No.
Can I get like 800 of fentanyl? Some Pocazine.
No. All right. So in this instance, the patient is responding to nitroglycerin. It is not wrong, and I repeat, it is not wrong to consider pain management in patients who are really struggling with their pain. If you've administered multiple doses of nitro and it is not touching their pain, absolutely, you need to move on and you need to give something else that's going to be stronger. Morphine, fentanyl. What's the great thing about morphine?
You can reverse it.
What's that?
You can reverse it.
You can reverse it, which is awesome.
Short duration.
But yes, you're also going to have vasodilation and
Short duration.
short-term
Yeah.
duration. Yes, short-term duration. What's the great thing about fentanyl?
Doesn't.
It's easy to titrate. It's what?
Doesn't affect
It's not going to decrease your respiratory drive. And what else?
You can fix it.
Okay.
Doesn't affect the blood.
What?
What?
Did you just say you can fix it
Fix it.
pre-hospitally with what we have in our bags?
Yep.
With?
By not giving it.
I know how you feel.
All right, look.
I'm just asking.
Everybody around the duck.
Okay. So each medication has its pros and its cons. Okay, and it's definitely something you guys have to be aware of. What happens when your patient's pregnant? Now what?
Don't give her anything.
She's gonna get some
After.
oxygen.
Right, you have a
What's
female
that?
partner.
She can have some oxygen.
You're gonna have to call
And
for
some
anything you want,
Zofran.
but think about your pregnancy categories for fentanyl and morphine. These are things that you guys have the information about now, so you need to start thinking about this stuff. I mean, it's crazy. We've got a lot of medications now that we can administer. So now we have to start thinking, like, okay, now what can we do? What's gonna be the best option? So, Colin, looking at this patient,
Yes.
you transfer your patient over. You're in the back of your truck. You're putting everything together. You're disinfecting everything. You're getting ready to go back in service. And your partner says to you, "Do you think we did the right thing? Do you think this was the right thing to do for our patient?"
See, if I was Kyle's partner, I wouldn't have asked.
Are you referring to our destination decision?
Everything.
I think she's gonna be fine.
Is your name Colin?
What he said.
It's my middle name.
We'll talk about it outside. I don't know, I don't think so.
Like meet me by the swing set kind
think
of
we
thing, or
follow-
like,
Yeah. Meet the flagpole. Meet me
all
at the
right,
flagpole.
I'll see you at the flagpole and we'll have a talk.
Yeah.
could
A
fly
what?
out easier
Talk.
than there.
Talk.
Walk.
Talking is when you're not upset. When you're irritated for no apparent reason, it's talking. All right. So, in this instance, as a general group, how do you feel? Do you know your ACS protocol? Starting. I would definitely say starting. How did you guys feel as a group in terms of the diagnosis of this rhythm?
Good.
Does that make sense? Is everyone on board? Did anyone look at this and say, holy crap, I have no freaking idea what that is? No. Okay. All right. What's that?
Said it's not centered on the page.
It's so not centered. It was. In
It's
my
really
role,
just
but-
matter of clicking it.
But I got it.
Most of that.
Pretty sure it's-
The D's on it.
Morphine is, fentanyl is not.
What are
That
you
last
doing?
one.
I don't know.
Who's that guy?
Yes.
Leslie
You see the little arrows at the bottom?
Morphine is the same
Boom.
with, I think,
They did look a
pretty
little
sure.
different. Mhm.